when you look at an X-ray, you can see the X-ray, you can see a fracture. It's fracture, non-fracture. But with CT, there's a little bit more thought that goes into it, and not everyone gets the chance to go through it properly through it. So we'll go through these and see what we think. So if you can open this one, have a look and see what you think. And what we'll do, we'll scroll all the way from the top. So I always scroll from the top, go all the way down. I always do a run through. So I highly, highly recommend. I say this to all my registrars. Do that thumbs up thing. So I've got this new camera, by the way, and I put thumbs up. Does that work? Yeah, there you go. Thumbs up. So, and I've been accidentally thumbing up, and it's been doing that, has it? Maybe. Right. So what you do is I genuinely just get people just do one scroll through, right? Just do that once. And after a while, I've been doing one scroll throughs on these things. You like things will just start jumping. You, oh, that's not normal. That's not normal. That's not normal. So I've done one scroll through. I'll do one more. So one scroll through. So regardless of what that report says for anyone, I recommend doing one scroll through and then reading the report. If you're a registrar, a radiologist, I would highly recommend doing one scroll through. And as time goes on, things you just spot things so quickly. Actually, it's really quite a useful thing to be able to do. Right, so let's go from the very top here. We can see that there is a contrast enhancement here. You can see the aorta is where I pointed it to be, but it doesn't look quite as bright as the spine there. So I wouldn't say this is an arterial phase. Let's have a look at that portal vein. That portal vein is sitting over here, and that aorta is there. And actually, that looks slightly brighter. So we're probably looking at a portal venous image, right? So this person's probably come in with abdominal pain. Let's have a look at the gallbladder. The gallbladder looks okay. That's a very common area for having pain. Liver actually looks all right. Other places to get pain is going to be the pancreas. So the pancreas is sort of leaf-like structure going like this. So I'll go up and down so you guys can see it. It's going like so, like that. And that looks okay. And the main way to do that is to have a look at the fat. So that's the fat there. You want to look at the fat there. You want to look at the fat there. And the fat around that pancreas actually looks okay. It doesn't look bad at all. And then you want to look at the kidneys because the kidneys can cause pain. And when you look at the kidneys, which are here and here, by the way, you can see the collecting system. You can see that perirenal fat. That looks okay. It doesn't look like it's particularly dilated. This one looks like it might be slightly wider than that one. So we might have to keep like kind of bank that in our minds that there could be something going on with this one for some reason. It doesn't look quite right. So yeah, someone's come in with a good answer. That's very good. So maybe look for a source or what could it be? So now let's go right to the bottom. I quite literally go right down here and then I'll follow it up. So you can see where my pen is, hopefully. You can see here, we're following, going like so. Sigmoid colon, right? Sigmoid colon, coming up to here. And then this area looks really weird, doesn't it? Doesn't look quite right. And then you come across to this point, and then you come up to the descending colon. So you ever get lost, always go for the descending colon and then come down, come across, and then look, right? If you ever get lost, if you get lost again, go for the ascending colon. Those are usually the constants. The sequel pole, everything else seems to move around a lot, but the ascending and descending colon are usually good places to look for to re-navigate, recalibrate yourself. Also, this area here is going to be the ileocecal valve. You know that because there's a bit of fat there, and that's because you've got these fatty lips. Fat looks like this, and therefore you get a little bit of fat around here, and you can see it kind of goes around like this. So therefore, that must be the ileocecal valve, and that must be the terminal ileum coming out of here. So far, what we've seen is that there's this very odd-looking area located within this area over here. So we've got sigmoid colon, but it feels like it kind of bubbles up and goes up this way, and potentially could be some sort of communication or something. Is it a communication with another piece of bowel? What's that one? It's just wonder, there's something going on here, right? So now what we do is go to lung windows. Let's get the lung windows. And thankfully, collecting minds are really good. You can actually use, like, just by pressing the numbers, you just like with your normal pack system, you get the lung windows coming up. And scrolling through, some of you have noticed that there is a bit of intra-abdominal free air. And for those that don't know how to spot that, first off, that's lung, yeah. Then you got diaphragm, but on the other side of the diaphragm, there's some air there. Can you see that black stuff? And you come to the top, and actually, yeah, just underneath the hemidiaphragm, there is some air. Let's see if we can find any more. And now, as you look, that is all air around the liver. Quite a lot of air coming further down. Another dot there, another dot there. See if we can find any more. Another dot there. Any more? Yeah, another dot there. A few dots here. A few dots here. Can we find any more? So what you can do sometimes is look for where the most air is going to be, right? Another dot there as well. Any more dots anywhere else? Not really. So if I didn't have the abnormalities that were sitting down in the abdomen, like down in the pelvis down here, and you had a whole load of air sitting within the upper abdomen, and you couldn't find a cause for it, then you would be, I don't think it's unfair to say that, oh, this could be in keeping with a perforated duodenal ulcer, although you haven't been able to find it, because you have a whole load of air located within the upper abdomen. But when you've got no real abnormalities located within the upper abdomen, right, like so, and the only abnormality you really get is down in the sort of pelvis and the sigmoid colon over this region, then you have to try and figure out, like, why does it look like it's abnormal here, but a whole load of air has gone upwards, right? And it actually is more likely that they've had some pathology down in the pelvis, and it's actually been around for a bit longer than imminently. It's less than a day. It's been around for more than a day. Maybe they have to been able to sit up. They've been able to walk around, and so then the air starts traveling up the body towards the upper abdomen. And actually, what happened with this patient is that they had a previous episode of diverticulitis, and they weren't feeling any better, and they had this sort of very sort of soft tissue thickening inflamed region over here, a potential sort of fistula, which would be a communication between two bits of bowel, which is kind of happening because of this. And they still had a whole load of intra-abdominal air, which meant that they could have a potentially continued slow leak. So what you can do in these situations is actually to put in some gastrographin under fluoroscopy into the rectum, and then sort of start taking repeated images and just see whether you can identify like a tract, or whether you can identify any spill into the abdomen. That's usually like a decent way to try and find if there is that kind of thing. And I actually did a lot of that when I was doing my St. Mark's job back in the day. So anyway, hopefully that was useful. Someone did come out with it, perforation. So that's very good. Well done. You picked that up very well. Oh, yes, I did say I was going to go back to the. Yeah, thank you. I wanted to check something on case 7. Let's go back to case 7 for a second. And one of the things I mentioned was the left ureter looked a bit dilated. Not dilated, but it looked a bit prominent. And I was wondering whether sometimes what can happen is if you follow that down, that's ureter, keep following, keep following, keep following. Exactly right. So sometimes the inflammation that's resulted from something else can result in an obstruction of the ureters, because look, the ureter is going to be all the way down there. It's kind of creeping around this area over here, and then it's going to end up in the urinary bladder down here, right? So it has to sort of traverse or go through this area of fat stranding and inflammation and that kind of thing. And actually, when you come back up and have a look at the two ureters, that does look slightly wider. And you would almost, if I zoomed in a bit, you feel like that wall is slightly thickened, very, very slightly thickened. So I wouldn't be a betting person, but if you look on the side, it looks all right. But here it looks slightly thickened, slightly dilated. And I think that would be secondary to inflammation down there. So that's kind of, so it's good to keep thinking forwards as to what could be causing what, depending on the anatomy it is. And that was something I forgot to mention on that last one. So thanks you for reminding me about that.